Everyone's journey with ALS progresses at a different rate. Unfortunately, that journey inevitably ends with death. As a person with ALS, you have the right to decide what types of treatment, support, or interventions are employed to prolong your life. One such intervention is tracheostomy ventilation. Tracheostomy ventilation is an option when ALS progresses to a point where non-invasive ventilation is no longer adequate and secretions cannot be well managed. The decision to place a tracheostomy tube or to not place one must be made sooner rather than later. If a decision is not made by you, it might be made for you in an emergency situation. Dr. Lisa Wolf will explain this option in more detail, including what you and your loved ones will need to consider regarding this choice.
Hello, I'm Dr. Lisa Wolf. Tracheostomy ventilation requires a surgical procedure that is usually done in an operating room under general anesthesia. During the operation, a tracheostomy tube is placed into the trachea or windpipe. This method of ventilation is considered invasive because it involves a surgical opening which assists in breathing. With the assistance of technically advanced equipment, a detailed care plan, caregiver support, and financial resources, some people have successfully adapted to using invasive ventilation. Choosing tracheostomy ventilation brings with it several challenges, including significant financial cost and an increased requirement of caregiver time and effort. Around-the-clock care, either at home or at a hospital or a care facility, will become a necessity. That means you need to be with someone at all times. If you want to stay in your home, those who support your care will need to understand the intense time commitment and need for training. In addition to learning how to properly care for the tracheostomy tube, you may also be using a feeding tube and/or a communication device. It is best to employ an outside caregiver and/or enlist other family members to assist in providing that care so that more than just one person is responsible for your care. Making your decision about the use of a tracheostomy sooner rather than later is important. As Dr. Miller pointed out, if a decision is not made by you, it will be made for you in an emergency situation. Studies have shown that those who planned to proceed with a tracheostomy as part of a strategic care plan were much more satisfied with tracheostomy than those who had a tracheostomy on an unplanned emergency basis. Once again, the key is to develop a care plan that involves respiratory support and to share your decisions with your loved ones and care team so as to avoid arriving at the emergency room in respiratory failure and having someone else make decisions for you.
Like any other form of respiratory support, tracheostomy ventilation does not arrest the ALS disease progression, but it can prolong your life. Some people with ALS decide against tracheostomy ventilation. This decision is very personal. It is based on a person's values, on the level of care and support available, on concerns about changes to his or her quality of life, and on how the condition is affecting the lives of family and friends. Likewise, some people with ALS who choose tracheostomy ventilation decide to discontinue its use. Dr. Barbara Bishop, a specialist in palliative care, will discuss the outcomes of deciding not to use or to discontinue the use of tracheostomy ventilation.
People with ALS who decide not to use tracheostomy ventilation are those who are still deciding whether or not it is an option for them, usually continue to use a non-invasive positive pressure ventilation device, or NIPPV. Medications may also be used at this time to increase the level of comfort and to reduce anxiety. Like any respiratory support option, tracheostomy ventilation can be discontinued at any time. However, you need to be able to communicate your wishes. Often people using tracheostomy ventilation use eye movements to express themselves. If you have lost the ability to communicate for yourself, an advance directive such as a living will or the durable power of attorney for healthcare are the best ways to protect your choices. Discontinuing tracheostomy ventilation is done by removing the ventilator, which brings about death fairly soon after. If you decide to remove a ventilator, or if you've decided not to use one at all, you can be at home supported by hospice care. Generally speaking, hospice care works in conjunction with palliative care specialists, as well as your own clergy people, to help you remain comfortable physically, mentally, and spiritually to the end. There's no denying that talking about dying is difficult. However, the passing from ALS can be peaceful, comfortable, and at home for the vast majority of patients. But decisions need to be made ahead of time to plan for the inevitable.
I hope that by this point, you understand the importance of learning all you can about ALS and your respiratory support options as the disease progresses. Obviously, these videos cannot provide all the information you need to make these important decisions. It is up to you to be proactive about obtaining the information you need to make the best decisions for you and your loved ones. Discussing your wishes with your loved ones and your ALS care team and creating an advance directive are the only ways to ensure that your decisions are upheld. As long as you have a care plan in place, it's your decision.
I'm Debbie, and my husband Jeff has been diagnosed with ALS for the past 11 years. For the past 5.5 years, we've been on invasive ventilator support. This was a decision that we made early on through the process of talking with our doctor. His perspective at that time was he wanted to be around as long as he could talk to others and share his story with other people. We are able to take my husband with us many different places so that he can continue to enjoy life. It is a 24-hour situation. We always have to have somebody with him since he is unable to take care of himself. We have been able to do all these things due to a strategic plan in order to get the services that we need so that he can continue to live with us and spend time with us.
My name is Ann Kramer, and my husband had ALS for 18 years, and I was his caregiver. When he was first diagnosed, we were told that he would only have 3 to 5 years to live. So we knew that we needed to get some help and some information. The first thing we talked about was how much care we wanted to do and whether he wanted to go on with his life with ALS, and he said he wanted to live every moment until he couldn't live any longer. So we discussed a BiPAP machine, and he went on that. He got a PEG tube, and eventually needed to be put on a ventilator. It was a great thing and a hard thing to see somebody that you love struggling. But we had some really great times. We did a lot of traveling. My husband was on the Bay Area ALS Association Board of Directors, and we went to all the meetings. We went to all the outings. We did the walks. We did everything that we could. He was so excited about being able to put his story out. My husband was on BiPAP for about 6-7 years and then went onto a ventilator. As I said, Lee was on his ventilator for 4.5 years, but eventually his lungs weren't capable of carrying the air that they needed to. And the doctor told us that we were at the end of his life, that he had probably 2 weeks to live.
Hi, I'm Joe Scalabrini. I was diagnosed with this ALS disease and started to use BiPAP almost immediately thereafter.
As a family, we've decided against the tracheotomy and, trying to make plans going forward, what works best for all of us as a family. It's just a very devastating disease, and we just try to make the best of each day and each moment and enjoy what we can at this point.
Yeah.
I'm Tamara, and I've had ALS for 3 years. I have not been able to speak for 2 years, and I have not been able to eat or drink for 1.5 years. So I had to have a feeding tube put in.
My name's Ron. I'm Tim's caregiver and husband, and we've been talking to our support group about options for Tam's ventilation. She's not a candidate for a BiPAP, so we're thinking along the terms of a trach or something like that for long-term ventilation. And we're just trying to use what we hear from them to make our decision for long-term ventilation.
Hi, my name's Renee. My husband Bill was diagnosed with ALS 5 years ago and died just recently. So we went to the hospital thinking that, we were going to get hooked up to an IV and that he would be able to come home. And that's not the way it happened. It turned out that his lungs were filling up and that his breathing was getting more and more impaired with the weakening of his diaphragm muscles. And so it turned out that he ended up having to be taken to ICU, and standing in the ICU department with the doctors, there had to be a decision made as to whether he would be intubated or not. We had done planning, which I'm so thankful that we did. We had a DNR, and on the DNR, Bill had indicated no intubation and no invasive ventilation. So I'm standing with the DNR, the doctors are asking me what to do, and I said his wishes were for no intubation and no invasive ventilation. And they were trying to follow that path, but then our ALS pulmonologist pulled me aside and talked to me and said, you may want to reconsider. She said, if we go with his desire of no intubation, he will die right here. And there is a chance that he can come off of intubation, he can breathe on his own, and also just the opportunity to have his children to be able to come and spend time with him. So I really didn't think he'd be able to come off the intubation successfully, but feeling as though there was a chance for his children to be by his side, at that point I opted for the intubation. So we were all able to be with him for a week. It was a difficult week. It was one of the most it truly was, in my life experience, the most difficult week in my life, but yet an amazing week of expressing love and compassion. We all surrounded him. There was laughter, tears, singing. And at the end, when we made the joint decision to extubate and have the breathing tube removed, we knew we were all at peace with that decision, and we were all there for him. And we surrounded him with love. He died peacefully. He died a happy man. He died surrounded by love. All that anyone could ask for. And I'm so thankful for having had this opportunity to be with him and to make these sorts of plans.
I have been trach for a little over 2 years. I knew from the moment I got the ALS diagnosis that I would need a tracheostomy and a PEG. This insight came from my nursing background. I did have somewhat of a strategy. The ALS clinic and myself followed my PFDS. This makes you more aware of the time when assisted breathing is needed. I first went to BiPAP. Very quickly I was unable to apply or remove the mask, so I had some great friends stay overnight and assist me. They hated that mask, the torture it caused me and my friends. Shortly thereafter I had the discussion with my private physician, and my good college friend from nursing school was also with me. We did talk pros and cons and cried. I did know my care would ramp up to 24/7. In 2 weeks it would be a tracheostomy. The adaptation continues, and I want to live. This is my only choice. Let's do it. It was never 2 weeks I got seriously ill. My tracheostomy was now pushed ahead of schedule. When you are having difficulty breathing, you want help. With the tracheostomy, I could breathe naturally again. That recovery was long due to the severity of my illness. I got ill again over a year ago due to a respiratory infection, but not hospitalized. I am energetic and do whatever I want to do. I go to the spa, wineries, baseball games, concerts, restaurants, and festivals. Nothing stops me. Would I do it over again? In a heartbeat.